Okay, so up next we have another newborn screening state experience. Today we're going to be hearing from Dr. Bonkowsky and Utah, which I believe started screening in 2020.
Yep, thanks for the chance to talk. And
welcome.
Let's see if I can make this work. Am I showing the right set of slides to everybody? So thanks for, again, the chance to talk. And I'm speaking on behalf of a large group of people who've made this all possible. And I know the state lab is being crushed right now with COVID, so I'm not sure if they'll be able to join us at all today. So they've asked me to speak on behalf, so I apologize for any lack of knowledge I have about some of the finer details. And so some disclosures, nothing really relevant to what I'm talking about today, but just to be fully transparent. So just to remind everybody, that red state there in the middle, that's Utah. And I'll be talking a little bit about just some background on Utah and kind of our geography, because it's relevant to how we set stuff up. So this is a heat map of population in the United States. And the location, we're right here in the middle. There's not really other large urban areas for a long way. So it ends up, even though it's kind of a low population density area, it's such a big geographic area that everything kind of flows towards us in about a 400,000 square mile area. That's about the area of France plus Germany combined, so it's a big area. And even though it's less population dense, it ends up being about 1.7 million children who live in that region. So a large area that we're kind of responsible for. So this region is known as the Intermountain West because on the one side to our east is the Rocky Mountains, and to the west is the Sierra Nevada range. And that's how I got its name. It ends up that this region is currently the fastest growing region in the United States, with Idaho, Nevada, Utah, and Arizona all having kind of the fastest growth rate over the past 10 years. Utah is no longer a white state. It now has a 22% minority population, so it's growing a lot. And interestingly, the highest rates of growth in the minority population is actually from the Asian population here in Utah. So it's changing a lot compared to how it was 15 or 20 years ago. So this is a picture of where we are right now. So that's me there at the bottom of the arrow. This is a picture of Salt Lake City. The university and the hospital is there on the left side of the screen with the arrow pointing to it. And then the downtown area is to the right. The Shriners Hospital, for example, is these kind of blue domes right here. And then you can see the mountain range in the back there. Those are called the Wasatch Mountains. So one of the things that's really been special for setting up the program here is the partnership. And so the hospital where we work at and see kids is called Primary Children's Hospital. The Primary Children's Hospital is a collaborative effort between two major institutions here. One is the University of Utah. There's Intermountain Healthcare. And so these two institutions are both large and often competitors in most spaces. But the Children's Hospital, they actually work together. So the Children's Hospital, the building and everything is run by Intermountain Healthcare, which is kind of like the Kaiser Permanente of the region. But then all the physicians at the hospital and the nurses are on the outpatient side at least, just applied from the university. And so this partnership is really kind of unique in having kind of a mix of academic and like large population-based efforts. So the hospital ends up getting referrals from across the regions, so not just Utah, but also because there's not other children's hospitals, we get children coming from Montana, Wyoming, Idaho, and parts of Nevada, Arizona, Colorado. So essentially any child who needs specialized medical care ends up at the hospital, and it's the only place to get specialized medical care in about a 500-mile radius, so a really large area. And then Utah itself, although the population isn't huge, it has the highest birth rate in the United States, so about 50,000 births a year. So really an ideal place to try and get newborn screening up and running. And so we're, because we're at the hospital, we do have access to special resources. All the hospital records track births. So most births in Utah are one of these two large systems that we have access to. All the specialized care, for infants, is occurring at the hospital. So whether you're seeing neurology or genetics or cardiology, those records are seen by us. And there's very few providers across this entire region in specialized care. So up until just a few years ago, there was no other pediatric neurologist until you flew to Denver or flew to Sacramento. We've been fortunate to really partner closely with the newborn screening lab. So they're basically, they used to be about 100 yards from where I work. So I could just walk over there and harass them. Now they moved a little farther away because they got tired of me harassing them, but this partnership is really good. And then we've also had a clinic here for leukodystrophy, including ALD, since 2006. So just a long track record. And then, although not really relevant to today as much, but we do have a large database where we can track all these records. So this data warehouse allows us to kind of track people over time and kind of see how our care, does good things or bad things for them. So that's been really helpful. Utah has this long track record in use of genetics. So it's one of the places where the breast cancer genes were identified, for example. Now it's doing stuff more with using next generation sequencing. And so we have kind of these resources that we can use with patients. So something called rapid whole genome sequencing to help diagnose patients quickly if we need it. A large population study called Heredogene, where we're sequencing 50,000 kids. So I think we're gonna actually be picking up some kids with ALD through this program that might not otherwise be picked up. All this data is in something called the UPDB, the Utah Population Database. So it basically has pedigrees for families across Utah, which is a really powerful thing for understanding relationships. And then the state lab has been doing exome sequencing on any positive or abnormal test results. And that's been actually really critical as we set up the program in ALD screening to understand some of the test results. So we're getting both results from the state lab as well as results from a commercial partner to kind of see what the genetic test is. So let's focus then just on Utah and the numbers here. So the overall population, the most recent census has 2.7 million individuals, and it's had a nearly 20% growth over the past 10 years. So just 2 points. One is that most of the population lives along this area right here. You can see in the middle of the screen. That's called the Wasatch Front because it is right next to the mountain range, the Wasatch Mountains. Whereas other parts of the state are very less population dense. So of course, that means we're getting more births from the Wasatch Front. But for example, just recently we had a patient from the middle of the state with an abnormal test result. And so they'll have to drive several hours to see us. The diversity has really changed also in Utah. So this is a diversity index. The highest diversity is in the large urban centers here in the middle along the Wasatch Front. But for example, in the southeast corner of the state, this is the Four Corners region. So this is where there's a large Native American population here. And a lot of the births there are not necessarily occurring in medical centers. So that's something that we have to kind of work with the population there to make sure we're screening folks for ALD and other conditions. So just to follow up on that, again, the front here along the Wasatch Front is highly urban, but then as soon as you get out to these other areas, these actually fit the definition of frontier or rural locations. And so it's just a very different feel to our population that we take care of. So the newborn screening team is myself. I didn't include my picture here, but we have people in the Department of Pediatrics that work with us both for leukodystrophies and for ALD specifically. So Emily Hardy, who many of you might know, who's on this call, Heather Fairfield, one of our clinical nurses who helps take care of patients with me in clinic, and then Kristen Wong, who's our genetic counselor working with ALD and other leukodystrophies. And then of course, the state lab, that partnership is critical. So Andy Rohrwasser leads the newborn screening. So Andy Rohrwasser leads the newborn screening effort. And then Kim, who didn't provide a picture for me, oversees a lot of programmatic efforts. So this is kind of the timeline over the past 4 years to make ALD screening go live in Utah. So as you know, in February of 2016, ALD got added to the RUSP panel. And so then in April that year, we actually initiated discussions in Utah. And really, we thank Elisa and members of the national ALD community and actually international ALD community for giving us resources to help bring to those discussions. And so we had discussions with what's called the NSAC, or the Newborn Screening Advisory Committee, and we got approval fairly quickly in 2016 to move ahead with trying to get ALD on the screening here in Utah. So in 2017, we requested funding from the state legislature, and Utah historically is very budget conscious, and so we had to be very kind of savvy about the timing of the request and kind of staggering it so that we wouldn't basically run into resistance for requesting funding. And in March of 2018, funding was approved. And then essentially to get it integrated into the workflow, do the validation steps, took close to another 2 years. So kind of a slow process, but wanted to get it all correct. And then in September of 2020, we actually went live with screening. And so we basically have modeled our screening process as well as notification process on previous work done in New York and also in the Netherlands, in California, to try and make sure we do this well. So it's an LCMS screen with cutoffs for C26 levels. And so of course, if it's normal, there's no further steps, but if it's elevated, there's both a repeat on the first sample, and then if it's still abnormal, the second newborn screening is also occurring. And again, if it's elevated, we'll be notified. So any abnormal screen automatically will get popped over into the second newborn screening, and then we're also doing the second screen to enter our workflow. And so I'm getting notified when the abnormal screen is showing up again for the second time. And at that point, we're reaching out specifically to the primary care physician and also to arrange an appointment for the family so there's not a time lag. We get the appointment set up, we bring the family in. At that point, we're sending confirmatory testing for very long chain fatty acids and also sending genetic testing for the ABCD1 gene at that point. At that point, we're also arranging follow-up with us in clinic as well as with endocrinology, and then also working on arranging follow-up with our genetic counseling team. So we've had, full disclosure, because of the just complexity of communication. Sometimes the primary care physician has been getting notified before I was aware on the same day. So sometimes that creates a little stress just in terms of coordinating appointments. But it's actually worked pretty well in terms of not leaving families or patients kind of hanging, waiting for appointments or waiting to kind of talk to a specialist. So, there's some aspects that have been really unique for making this work well. One is that we know and work directly with this, the screening lab, with the state's newborn screening lab. So that partnership's been really helpful. And we try to attend intermittently or semi-regularly the advisory committee just so we can all be on the same page. We're also fortunate that because we're not a huge state, that basically all the information is kind of flowing through our team with myself and Emily and Heather and Kristen. So that really makes communication easier. And then the follow-up labs, including genetic testing, the very long chain fatty acids. So for example, the very long chain fatty acids are being analyzed here locally by people that I know personally and have their cell phone number to kind of see what's happening with the results on the labs. So currently we're trying to not contact, we're trying to make sure that we establish contact between our group in our ALD clinic, myself and Emily and Heather, with the PCP. So the PCP is now wondering what's going on, and then kind of in a unified fashion reaching out to the family. And that's worked pretty well. We've been also successful, basically at the family's discretion, trying to get them in the same week or within a week or two for their first appointment, and then trying to make the appointment as comprehensive as possible, just because a lot of times families are traveling from fairly far in to see us. So just looking at the numbers, so we started in September 20th, 2020 as the first day. And at this point we screened, well, so now, this is through December. So at this point we probably screened close to 60,000 infants. We haven't had any false positives. We've had no non-ALD positives, and we've had 7 ALD positives with 6 males and 1 female. So this just shows you the numbers with our C26, lysis C26 levels on the first screen, second screen, and then the very long chain fatty acid results, and then the ABCD1 variants. So interestingly, the ABCD1 variants are often ones that have not been reported in the literature, but based on the elevated C26 levels, the elevated very long chain fatty acid levels, and then kind of discussions about the pathogenicity of the mutation, we've been assuming and acting on the assumption that these are pathogenic variants because we don't want to take any risks. The last patient here, we haven't yet seen in clinic. We just got the results basically at the beginning of this week, and so I don't have information on that patient. So, to kind of briefly summarize, we're seeing about 1 in 10,000 live births with our screening at this point. We went close to a year with no positive results, so we were starting to get a little anxious. And then they all kind of have come in several big clusters just to make it really stressful for us, and of course for the families as well. Interestingly, with the families, maybe with one exception, interesting with these families, maybe with one exception, no one really has any history in the adults of neuropathy or other type of symptoms that make us think of AMN, despite the fact that oftentimes the parents are testing positive for the elevated very long chain fatty acids and the same gene variant. So we're not sure why that is. So that's something that we will have to kind of follow up on. And that's a quick look at newborn screening in Utah. And I think we've been really fortunate for all the help we've gotten from the community. I started not knowing much about newborn screening 5 or 6 years ago, and I know a little bit more at least. And I've got great colleagues who tell me what to do. So I think that's the critical thing, that having good people to tell you what to do and help you makes things go well. So thanks for the chance to present, and happy to take any questions.
Thank you so much. We do have one question so far in the chat from May Baker. Any false positive results in Utah?
We haven't had any false positives yet, knock on wood. So I think the state lab has been very careful, and they've also did a lot of validation steps. They were quite, I don't know why. I mean, it's just chance, of course, also. So.
No, your program is good. It's not chance. I think the method matters is why I ask. So yeah, I think the negative flow mode, the flow in the LC looks pretty good. Thank you.
Yeah, I mean, I think the other thing is we've also, the fact that we really got rolling in 2020 helped us, because then at that point, several other states have had to troubleshoot stuff, deal with supplier issues. I think there's been some, discussion in the newborn screening community about, the reagents and stuff that are being used. So I think that we benefited from other people having to deal with issues and paying attention and learning from their experience.
So would you mind just, maybe I didn't get quite right, because it sounds like from your flow chart, ABCD1 gene analysis is a kind of a little bit later. But also I heard you say in Utah, if we're screening the positive, you do the exome sequencing too. So where the stage?
So I apologize a little bit. I went through it quickly, so I didn't explain it very well. So from a clinical return of result to patient, we do the ABCD1 genetic test at the time that I'm seeing them in clinic for the first time. But the state lab is part of a research protocol. So under research guides, or not research guides, but under an IRB, has also been using exome sequencing for positive or abnormal newborn screen results as a kind of analysis to see how exome sequencing would it fit into newborn screening.
Thank you.
Okay, and question from Joe in New York. Hello, Josh. Sorry if I missed. Was the variant considered pathogenic?
Yes, so we had multiple, yeah, so we've had multiple discussions, and we're all the variants that we've seen have been associated with people, the folks have elevated variant chain fatty acids, and so we're going on the assumption that these variants are pathogenic. Of course, it raises the question of why there's no family history of anything, and so, but we can't, there's not really some other test, we don't want to like be wrong and like whoops, someone's developed cerebral ALD a few years from now. So we're going on that assumption at this time. And we have close track of patients, so if more information comes into our hands, from other centers, I think that'll be helpful. Maybe if we want if some variants don't need screening or something like that, but at this point we're being more cautious in screening and following patients.
Lisa, your hand's raised.
Yes, so thank you, Dr. Bonkowsky. I just had a quick question. Do you know how parents are told of the diagnosis? Are they told on the phone or are they asked to come in? Just curious on that part of it.
So it's probably, I think what's happening is that what is happening basically is that the primary care physician is calling the family saying, oh, your child's tested positive in the newborn screening lab, and the specialist will be calling you from the hospital. And then we're trying to call on the same day, like literally, like yesterday I called a family like 5 minutes after the PCP's office to try and say, oh, this is Dr. Bonkowsky, and we're concerned that your child may have this condition, ALD. So we're trying to make it a fairly compact discussion. We're trying not to tell them on the phone. Like we want to tell them because, because they may not be able to see us for a week. We don't want them kind of like out there stressing about something vague. And we're also trying to, although it's hard, we're trying to say there's a few good resources. Like we know you're going to go Google search this. There's a few good resources. And so it's important to come in, but it's not a crisis for the family on the same day.
Okay, so you direct them to resources on what to look at and, right?
Well, yeah, so basically I've been using ALD Connect just because I'm familiar with it, but I think when we have them come in, we have like a whole handout, but on the phone for that first thing, just trying to make it very simplified, straightforward, like important, but not a crisis today. Here's something reliable on the web, and we need to see guys and be 100% certain about the diagnosis.
Got it. Thank you.
Yeah.